And so thank you all to the many, many people who provided feedback and comments when you registered. We asked a couple of questions, and one of them was, what are you and your organization doing to improve PrEP equity? And there were a ton of questions, way more than this little sampling I created here. I was happy to see a number of people talking about rallying for a national PrEP program. We're definitely talking about a national PrEP program today. But I would also say these aren't either or sorts of activities. We need to do everything that's already listed here and advocate and develop a national PrEP program. All of these things are really important, and it's really encouraging to see so many groups across the country doing what they can to improve PrEP equity, because we know for a fact that we have a long way to go when it comes to achieving equity around PrEP access and availability and uptake in the United States. Yes, and a national PrEP program is where we are at, where we want to be at, I should say. This is the goal. Our next webinar, I need to give a little plug for, is coming up in a few weeks in conjunction with HIV Vaccine Awareness Day. It's called Just What is Discovery Medicine. We'll drop the URL or the link to register in the chat. We hope to see many of you who are here today on that call as well. And I should say we have over 400 people registered for this webinar today. This is the playlist that you were listening to. If you log in early, you hear all of it. Super exciting. Always a bespoke, curated music list for every webinar. I don't know why I'm so tongue-tied. And I have to, before I forget, special thank you to both of our amazing co-sponsors for this webinar, PrEP for All and HIVMA. And as many of you know, PrEP for All is really leading the charge for a national PrEP program, and groups like HIVMA, AVAC, and many others are working in conjunction with PrEP for All to see this come to reality. So I'm going to turn it over to our moderator in a second. I just want to note we have an amazing lineup of speakers today. Dr. Patrick Sullivan, Rupa Patel, and Lorraine Dean, and Dr. Greg Millet from amfAR is our moderator. Many thanks to all of them for working with us on this today. Really looking forward to their presentations. So with that, I'm going to stop sharing my screen, and I am going to invite Greg Millet to come to the podium, the virtual podium, and get us rolling on this webinar today. Thank you all so much.
Great, and thank you, Jim, for the invitation to speak today, as well as a thank you to AVAC and PrEP for All and HIVMA. This really is a timely webinar. And, you know, unfortunately, when we think about equitable PrEP access, this is something that I think all of us have been screaming about and were ready for a dozen years ago when PrEP was approved by the FDA. And it's a shame that we're having a conversation as late as today about some of the inequities that we're seeing and trying to figure out ways that we can address these inequities. We already knew a dozen years ago that we were probably going to fall behind in PrEP access for women, for youth, for transgender populations, for communities of color, for PWID. And this is something that didn't need to happen. So again, why is it happening? And what are some of the strategies that we can perhaps discuss together during this webinar to see if we can try and salvage a lot of the work that's getting done to make sure that we get equitable access for PrEP. And with that, we have a terrific roster of speakers who really are leaders in the area of gauging where we are with national PrEP programs, who are going to get us on a way to discuss what they're seeing and some of the ways that we can discuss collectively on how we address making sure that we have equitable PrEP access across the United States. Our first speaker is going to be Dr. Patrick Sullivan from Emory University. and he will be discussing inequities in PrEP across various states, as well as differences in outcomes in HIV cases. Patrick?
Are you able to see my screen?
Yes.
Wonderful. All right. So let me just get all the mechanics set up here. So thanks so much for this opportunity to talk about the issues of PrEP coverage and equity, which I think are related issues. And I'm going to share some slides. And at the end, if you have your phones ready, I have a QR code, and a lot of the information that I'm going to share is available on AIDSU.org to download and feel free to reuse. So we know that PrEP has been approved now for more than a decade, and uptake of PrEP has increased steadily from 2012 to 2022, ending in 2022 with nearly 364,000 PrEP users. But we know that PrEP use hasn't been equitable across the United States, and particularly across folks of different races, ethnicities, and geographies. And I think one of my main messages is that getting PrEP to the people who need it most is not only important from the point of view of equity, but also that's how we're going to have the greatest impact on reducing new HIV infections. So I want to talk about both coverage overall, and then who is covered, because both of those things are important. So when we look at the change in PrEP users from 2012 to 2021 in the light blue line, you can see that there's been, quite an impressive increase in the number of PrEP users. And at the same time, on a slightly different scale in the yellow line, there's also been since 2017 sort of a slow but steady increase in viral suppression. And I think, again, in terms of a serostatus neutral thought about how we need to act to reduce new HIV infections, both of these things are important. I note this because when we try to sort of tease out the levels of PrEP coverage and how that's impacting transmission and new HIV diagnoses, it's important that we take both of these into account. So as PrEP has been going up and as viral suppression has been going up, the dark blue line at the bottom shows that new HIV diagnoses have been going down. It's also important to say that there's not really equity among states about how PrEP is available and used. So PrEP coverage just represents the percent of people with an HIV diagnosis or with a PrEP indication who are actually receiving it. And so if we divide states out to show the range of how that coverage is across this decade, we can see that there's quite a difference. There's a threefold difference between the highest and lowest quintiles in PrEP coverage. And so in these 10 states, about 16% over the whole decade, higher than that at the end of that decade, compared to 5% in the low quintile states. And then these are just data about why coverage matter. And it shows, if you look at those groups of states and across this decade, how the outcomes in HIV diagnoses have varied based on the levels of PrEP coverage. So on the far right, this group of states, this sort of top 10 states in terms of PrEP coverage, experienced an 8% annual percent change, so the 8% decline per year in new HIV diagnoses. Conversely, the states that had the lowest levels experienced about a 2% increase in HIV diagnoses year over year. So the amount of coverage really matters, and that's a significant sort of trend. And then I think we also have to think about this issue of whether the communities that need PrEP are getting it most by geography or by other characteristics. And so I just wanted to show that this metric of the PrEP to need ratio, which really doesn't ask like what percent of people with HIV or with PrEP indications are receiving PrEP, but rather how equitable is that between groups? How much is it related to need? And that metric, higher would indicate higher PrEP equity. So this is work led by Aaron Siegler that showed that if you just look at sort of a snapshot of PrEP equity metrics and policy issues, that states that had both a PrEP drug assistance program and Medicaid expansion had sort of a double the equitable PrEP use. Equitable PrEP use is better in states that have one or the other of those programs. And so the message is that either policy moves us towards PrEP equity, but combined, they really move us along towards something more like an equitable situation of PrEP use. And so this just illustrates that in a different way and points out that if we look overall at Medicaid expansion states versus states that have not yet expanded Medicaid expansion, that the PrEP use rates are considerably higher. So I think we need to keep in mind these two mechanisms that we really have experience with and are attainable as priorities for policy. And then lastly, just thinking about this imbalance in terms of equity, and another way to look at that concept of equity, which is we really like for whatever the group is, whether it's by race, ethnicity, age, geography, or sex, that the proportion of PrEP users be proportionate to the burden of that community in terms of new HIV diagnoses. So, and we're far away from that. So this is an infographic from AIDSview that shows that in 2021, Black people made up 41% of new HIV diagnoses, but only 14% of PrEP users. Hispanic Latinx people, 29% of new diagnoses and only 17% of PrEP users. And white people, 25% of new HIV diagnoses, but are largely overrepresented in PrEP use. And so this speaks to where we're not serving people well with interventions that facilitate the use of PrEP. And along this line, if you think of these lines as representing the extent of equitable PrEP use by region and race, I just want to point out that this is true in every region of the United States. These equity gaps exist, with the purple line being that equity metric in white people, the yellow line in Hispanic people, and the red line in Black people. So this sort of stair-stepping of equitable PrEP use is present in every region, although the overall levels of PrEP use in the Northeast are higher. The equity gaps are actually higher in the Northeast. So I'll just end by summarizing that we can't end this epidemic without PrEP coverage and equity. So I showed you that kind of a dose-response relationship and with the PrEP coverage and the magnitude of decline in new HIV diagnoses, and higher PrEP coverage is better in terms of driving down new transmissions. I think that the idea of a combined approach to HIV prevention, that's timely diagnosis and availability of effective treatments, both play roles. That was the slide I showed you where the viral suppression is coming up at the same time as PrEP is. Medicaid expansion and PrEP programs are associated with higher equity in PrEP use, and equitable PrEP use is optimal prevention, and we'll get towards our goal of ending the HIV epidemic when we get PrEP to the people who need it most. And I promised a QR code. If you can grab this QR code, a lot of the panels and infographics that I showed are available to download on aidsview.org, or you can reach out to me if there's any of this information that you'd like to use in your own work. So I will pause there and hand things back over to Greg.
Great. Thank you so much, Patrick. That was a fantastic presentation. Really started us off nicely in terms of showing where PrEP access is, where it isn't, some of the geographic inequities that we're seeing, and more importantly, showing what's taking place in the South, that these inequities are perhaps least pronounced in the South, although they're there, and that PrEP use is also least pronounced in the South as well. Just really important information. From here, I'd like for us to transition to Dr. Rupa Patel from CDC to discuss injectable PrEP. and what we are seeing on the ground in terms of implementation of injectable PrEP. Dr. Patel.
Thank you, Greg, and thanks for the organizers. So I'll be discussing injectable PrEP and the clinical focus of the challenges that we see in PrEP delivery. And I'm going to really take a step back at the organizational level of PrEP delivery and our supply and talk about PrEP and access. And I'm going to break that up in cost. I know this is a cost-focused webinar and lead into the clinical challenges, but then go into these opportunities. Just want to highlight for the nation that in our PrEP prescribing today in a large database of our over 186,000 PrEP prescriptions, where we're at today is 50% of people are on generic PrEP. And we really have, even today, after 2 years of FDA approval, we have only 0.5% on cabotegravir. And the highlight of the slide is, generics are really important. We're seeing that trend. There's been a lot of analysis done about cost effectiveness and people getting more access when you have generics. So that's the first call to action in this presentation is essentially, we as a community, while we're talking about PrEP financing, I hope we can also talk about kind of the advocacy around getting more generics in the field and creating faster timelines to get those generics to us and to internationally. And I want to highlight something that was discussed in the last few months. When we start looking at healthcare delivery will always be the office visit, laboratories, and the medications when we look at PrEP care. And we can't look at PrEP care without these three components. And when we look at costs and the barriers to access, the second call to action to the community is really to break down the level of cost by these different mechanisms and elements. And so there was a abstract at CROI 2024 where they for the first time actually looked at non-medication costs after the ACA or the Affordable Care Act provision, which says we should have no cost sharing. And what was remarkable is when they looked at this database of over 130,000 people using market scan data in commercial insurance, they saw 1 out of 3 commercially insured persons were charged cost sharing despite ACA financial protections. And what was quite alarming is actually the mean annual amount out of pocket that somebody is paying is over $200. And 50% of that cost is the provider visit, is to get your prescription. And then a substantial amount of cost was actually the HIV test, something we regard as essential to be prescribed and to maintain on PrEP. And this bar graph nicely lays out everything from lipid testing, creatinine testing, sexually transmitted infection testing. And the take home to you today is that the provider visit, preventive counseling, HIV testing, and creatinine testing, what we deem as pretty primary and essential for getting PrEP today, had large out-of-pocket costs among people that were charged out-of-pocket during this no cost-sharing era. And again, it's the third call to action about really having compliance to what we have today with the the Affordable Care Act in America. Next, I wanted to delineate the medication out-of-pocket costs. Like I said, there's the provider visit, labs, and medications. And what was disheartening in this analysis done in 2022, it showed that still, when you look at the right-hand side of the graph, in 2021, people that were paying out of pocket were still paying over $800 just for the medication alone. Again, it has nothing to do with your provider visit. So, when you start putting all these numbers together, someone that's paying out of pocket may very well be $1,000 plus a year. So these are great numbers to take to the field and to start looking at an advocacy level. You know, Patrick nicely laid out expansion. This is just a plug to action where when we have Medicaid coverage, and we want to remind people today on the clinical side, and the clinical plugs are, PrEP is the gateway to primary care. It is a door that opens access to mental health services, social safety net situations such as food security and housing, as well as substance use assistance. And so providing insurance not only gets you PrEP, as you see when there's no expansion prior to 2017 and expansion post 2017, but it gets you primary care. And this was a look that CDC did in 2024, just a few months ago, where you looked at PrEP to diagnosis ratios, where you had PrEP coverage as the numerator, and the denominator was HIV diagnoses within the last year. And I want to put a plug at the Biomedical Summit just this week. You know, health departments were discussing how are they kind of creating a system at the state level to provide PrEP, but not only PrEP, public health insurance. In Colorado State started talking about, as someone walks in the door in their state-run and local-run public clinics, when someone is insured, uninsured, Medicare, or underinsured with commercial insurance, how did they create a state level program in order to supplement what someone needs when their insurance doesn't cover it? And this is what states are doing. We need to advocate for that, but we also acknowledge, and especially the audience here, that this is kind of a patchy solution to providing PrEP, and that is why there's a call for more centralized financing. And it turning into a clinical deep dive, I wanted to overlay in this framework in implementation science research. When we start looking at organizational level challenges, we can divide them in 5 domains. It's basically the intervention. This is PrEP today, and we can talk about long acting. We have the outer setting, which is the policies, and we've talked about cost. And then we have the inner setting at the organizational level. What are issues going on? And then the provider level, and then kind of the overall workflow. I'm gonna, in my next slide, discuss the overall workflow. But when we talk about challenges today at the organizational and the community level, I want to remind people injectable PrEP today can offer remedicalization. So, you know, our next call to action is we need to demedicalize the remedicalization that injectable PrEP has caused us, because it's essentially having to be administered by an individual in the healthcare system, and it has to most likely be in the setting of the healthcare system. So we really need to create policies to get injectables and oral PrEP in the home, on the street and shelters, and also very importantly on mobile units. And so when we start looking at the policy level, in addition to cost, you know, there is this situation of clinical guidance and all the different levels you need for testing, in addition to our legal frameworks. And then going back to the remedicalization, remember, healthcare regulation and not allowing community health workers or medical assistants to be in the field and help offer treatment and prevention, both for HIV and STIs, and HIV prevention such as cabotegravir, but also syphilis treatments such as bicillin, doesn't allow us to address this endemic. So I'm going to have this buzzword of healthcare regulation here and there throughout this talk, especially through the opportunities. In terms of the inner setting, you know, I'll talk to you about the workflow on staff coordination and staffing. Unless we task shift, we are not going to get PrEP out of our clinics, and we're not going to get them delivered by pharmacists in pharmacies, as we've seen a national trend. You know, in general, we're going to have to really start changing the climate and culture of healthcare settings to have other kind of units and other prongs to healthcare really extend out of the clinic and into mobile units, etc. I want to remind everyone, as we move into the era of injectables, we really have to be in tune about awareness and comfort at the individual level, such as needle phobia, the awareness and kind of the medical mistrust about long-acting products in your body. And we're really going to have to work with the leadership in these organizations at an organizational level to really put PrEP and long-acting and non-long-acting formats of PrEP and the competing priorities and kind of the main priority when we're going ahead and rolling out care. I want to transition to the slide about workflow at the organizational level that sometimes into if you're not in the day-to-day grind. And the slide is broken up into basically 4 color schemes about how care starts. So first, a provider with a prescription is going to assess if you can receive oral PrEP. And I want to say that because generics are very different than non-generic PrEP today. And some people need that smaller pill. And so they'll want a brand name. And then we'll also have injectable PrEP, so cabotegravir. What's happening today is because insurances are not covering PrEP without prior authorizations, people are doing what we call a test script. And they're sending out a test script to see if it's covered and what the potential wait time is, because we know from data that came out at CROI that essentially it's almost 1 month before you can actually send a prescription, do all the paperwork, and then go ahead and get that injection at hand. And why that is complex is because once you get the injection, you have to time the actual patient visit and the call to the client to go ahead and come to the clinic to get injected. These are several steps, and people lose motivation during that time. Then you're going to go ahead and after you can see if you have insurance coverage, what is the cost, what is the prior authorization paperwork, including sending all the medical records and writing special letters to the insurance company, you're going to obtain the medication. And this medical acquisition is a huge barrier to medicine access today in the United States of America. And when we go ahead and when we get the medication, we have pharmacy benefit. So the next call to action is really to shift medical acquisition to pharmacy benefit over buy and bill. And buy and bill essentially means that I have to pay as an organization over $100,000 to buy medication, then inject, and then bill insurances to get that money back. And there are times where several organizations have reported that it's taking about 4 to 5 months to get over $100,000 back. So the organization is in the red for that time period. This causes extra documentation. Injections sometimes have to be shipped, and then you have to get reimbursed. There's extra logistics. And then you have to time everything to a scheduled appointment. And we know 1 out of 5 appointments are being missed. And then we know we have to go ahead and then actually give care. Actually, someone schedules an appointment, you actually deliver care, get labs, and then you have people that switch or discontinue. And then you have to go back after the medical visit, you do medical documentation, and then that gets your money back. And you can see there's a pharmacy communication system, a scheduling system, and a billing system, and a care system. And then with all these systems, you need a full-time coordinator and more money. And so this leads us to the opportunities. Healthcare regulation really needs to foster differentiated service delivery with task shifting and the locations for task shifting, pharmacies, mobile units. We really need to have a syndemic approach, and we need to really learn from policies from mental health, family planning, COVID that allowed really innovative care. And we have to highlight that in Washington, they passed the bill, the Washington state governor, where you can have bicillin injections to tackle the syphilis epidemic that we see today, where medical assistants and disease intervention specialists can actually off-site, so that means out of a clinic, inject through telehealth supervision or standing orders. And that will be a breakthrough legislation for our nation. And we need to actually have a call to action for all of us in our different cities, talking to our mayors, our governors, and our health department officials, so we can have local and statewide legislation advocacy and a change of legislation. And then, of course, we've been talking today about financing and Medicaid expansion advocacy, as well as other dedicated program financing advocacy. A model that I want to plug that has been a model for the nation about community health workers is the Whitman-Walker model, which are PrEP specialists who don't have a formal medical license, and they have been successful to have large rollout in Washington, D.C. And in summary, we have PrEP users are charged cost sharing for medications and services today, despite financial protection. So we need to have ACA compliance. Clinical workflow challenges really contribute to inaccessibility, and that is why we need policies around healthcare delivery, regulation, and financing to foster equitable PrEP access. Thank you for your attention, and I'll turn it back over to the moderator.
Thank you so much, Rupa, for an excellent presentation. Incredibly comprehensive in its scope, with some really lasting taglines, I think, for many of us to remember, from PrEP being a gateway to primary care, to demedicalizing the remedicalization of injectable PrEP, as well as all of the incredible information that you offered on out-of-pocket costs for PrEP. And that actually is a very nice segue to our next speaker, Dr. Lori Dean from Johns Hopkins University, who is going to be talking about the costs that's associated with PrEP and PrEP access. Dr. Dean?
Thanks so much for that introduction, Dr. Millet, and thanks everyone for attending today. We appreciate you and the work that you're doing. As mentioned, I'm going to be talking more about the cost landscape for PrEP. I can get my slides to work. Everyone should be able to see them. And the title of my talk is Cost Still Matters to HIV PrEP Uptake in the US. As Dr. Patel alluded to, she really set a nice stage and a nice foundation to talk about this, because I do think that there is, in some circles, an undercurrent that cost might not matter, or cost might have no longer be an issue, but we know that that is not true. So what's happening in terms of the US landscape? One is that the US Preventive Services Task Force gave PrEP an A rating in 2020, which essentially means that private insurers and Medicaid expansion programs who want to comply with the Affordable Care Act should be offering PrEP and their related services with no cost sharing. Yet, as Dr. Patel mentioned, she brought up that point that 1 in 3 commercially insured people are still charged cost sharing despite these protections. And there's also some ongoing threats to this actually being covered. So one of them is there's the recent legal challenges that really threaten to upend what we call no cost or $0 PrEP. One of which is, oh boy, lots of things are happening. One of which is a case that's currently happening right now, Braidwood versus Becerra. So Braidwood Management is a Christian-owned business that plus 6 individuals in Texas who assert that the requirement of preventive coverage is unconstitutional, and particularly in the case of PrEP, which prevents an STI, that the coverage requirement violates their religious rights. This case also questions the limits of the authority of the USPSTF recommendations in their role. So this is an ongoing court case that we're still hearing things about. There are still things coming up. But one of the, in September of 2022, a federal judge in Texas had sided with Braidwood. They struck down the mandate, but the federal government appealed that, the ruling in 2023 to the Fifth Circuit Court of Appeals. So currently it's allowing this coverage mandate to remain in place while this case is being deliberated. But we don't know what the what the results of this case will be. And this could really potentially, this is a real concern in terms of not just PrEP, but PrEP particularly, but then also thinking about other things that are covered under this no cost sharing mandate of the ACA. Also, other things have been happening. So, for example, insurers have found, are using different means to circumvent $0 PrEP. So, limiting formularies or listing PrEP drugs on the wrong tiers to discourage use. So, there are, and on top of that, there's also some concerns about the manufacturer reimbursement programs for the 340B safety net clinics. And that is to say that many of the programs and many of the places that would offer PrEP and offer PrEP-related services, their funding is also being undercut. So all of these things speak both to cost of the medication, as well as time costs, as well as costs for other related services. All of these things are still important and still matter to PrEP. And that's what some of our research has been doing and trying to show. So the first study that we did was something called Predicting the Impact of Cost on HIV PrEP Uptake and Racial and Ethnic Disparities among gay and bisexual men who have sex with men. And this was an R21, an NIH-funded grant conducted by me as well as some colleagues at Hopkins and University of Pennsylvania. Phil Chan led a team at the Miriam Hospital, and Julia Raifman led a team at Boston University. And this was a study where we tried to better understand, and this goes back to something that Dr. Patel said, it's not just the medication cost, but there are other elements of cost that we need to think about. So in this particular study, we presented people with scenarios, and those scenarios tried to simulate what someone might have to do and what sort of costs people might be exposed to when it came to PrEP. So if you look on this first column, these are the different cost-related attributes. So one was the cost of the medication, another one was time costs. We also thought about side effects, and then we also looked at the various ways in which people could receive PrEP. So what mode of administration? Would it be an implant? Would it be injectable? Would it be something else? On the other side, we varied up the types of scenarios that people got. And we call these the various levels of each of these attributes. And these levels correspond to, for example, different intensities. So different intensity of cost, different intensity of time, different intensities of side effects, and different types of administration. So what we found in this study is that side effects and costs really emerged as the top concerns. And this was particularly looking at gay and bisexual men who have sex with men in New England. And these percents that you see here reflect the importance of these issues. It essentially tells us how much influence each attribute has on someone's decision to want PrEP. So as you can see here, 44% of people's interest in PrEP would be dictated by side effects, and total cost was 35%. But what this doesn't tell us is about the range of acceptable costs or the focus of costs or the focus of the cost. And we'll talk about that a little bit later. What I'd also say, even though cost came in second here, right, cost is also one of the most modifiable factors. Side effects, it's challenging because side effects affect different people differently. There might not be a lot that we can do about that, but cost is certainly a concern and something that we can do about, as well as things like time to get to visits and people's options for mode of administration. But what this also tells us is that, as Dr. Patel mentioned, as we think about these new modes of administration, that actually might be less important to people. So if we can tackle some of these other issues, people might be open to a very wide range of types of PrEP modalities, which is really good news. What we also saw here is that when we looked among people who had low interest in PrEP, and in this study, we looked at people both who had taken PrEP before as well as who had not used PrEP before, and among those who had not used PrEP before, what their interest in PrEP was, cost actually eclipsed all of the other factors. So if we want to think about engaging people in PrEP who have not been engaged in PrEP before and potentially might be indicated for PrEP but have low interest, we really do need to make sure that cost is not a barrier for those people. We also saw that all along, people wanted PrEP to be essentially low cost. So the ideal package to offer PrEP would be that it would be $0, that it would take less than 30 minutes to access, that to the extent that it could be no side effects, And people actually preferred the injection every few months. And again, we think that kind of filtered back into people wanted this to be low time burden. So we know that if we want to order PrEP and make PrEP the most attractive to people, we need to reduce all types of cost burdens, including out-of-pocket costs. But we also know out-of-pocket costs are still a factor. And in fact, we did another study to assess gaps in PrEP initiation and retention and trying to understand the role of cost. And we did this using pharmacy claims data. So this included some of the investigators before. This was another NIH-funded study. This was an R21 led by Amy Nunn and I, as well as, and included other investigators at Hopkins, at Brown, at Penn, and at Miriam Hospital, as well as other collaborators who worked on parts of this study. So in this study, we used pharmaceutical claims data for oral PrEP from the period October 1st, 2015 to September 30th, 2019. So we assessed some outcomes using the largest pharmaceutical claims data set for PrEP, and that was provided by Symphony Health Solutions. I think it's also now called Source Healthcare Analytics, that covered 80 to 85% of active PrEP prescriptions in the US. It also included most public and private payers, which was really great. It essentially only excluded those that don't share their data publicly. And it also included demographics and health outcomes, so we could look at both who was not picking up PrEP, as well as what sort of health outcomes, what sort of HIV outcomes they subsequently had. We looked at particularly patients who were newly prescribed PrEP. So that is people who had no HIV diagnosis or PrEP use as of 2015. And in this case, I don't know why this slide moved ahead. In this case, we looked for claims for Descovy. Descovy was not included, Descovy was not included as it had not been yet FDA approved. So in this study, the patients were the units of analysis. We followed them for up to 1 year after they were prescribed in 2016. 58,000 patients were included, the vast majority who were male. We had a range across ages. The majority were non-Hispanic white, though let's just say the plurality were non-Hispanic white, though we also had representation from non-Hispanic Black, Hispanic Latine, and other races. Education, we also had a spread of education and household income and insurance type, though most people were commercially insured. And the initial part of the study actually looked at something called PrEP reversals. And I'm not sure what happened, but somehow my PrEP reversal slide disappeared out of this. And the idea behind pharmacy PrEP reversals was this is a way to think about who is not getting PrEP initially. So the idea behind the PrEP reversal is that someone will go to the pharmacy point of sale and for one reason or another, not receive their PrEP. It's called a reversal because the pharmacy literally reverses the prescription in the system back to the insurer. So the insurer has already done their part and they reverse it back to the insurer. And what was interesting about this metric is prior to this, whenever we thought about PrEP initiation or adherence, we often calculated it based on a metric where someone had to pick up at least one or more prescriptions in order to understand whether or not they were adhering to PrEP. But this was a new metric that enabled us to look at people who had never picked up PrEP. They never actually started picking up their first prescription. And what we found in our previous study was that 1 in 5 people who were newly prescribed PrEP did not pick up their first PrEP prescription. And when we looked and played that out across HIV outcomes, one of the things that we saw, unfortunately, is that that conferred up to a 5 times higher HIV risk in 1 year alone. So in other words, we might be able to prevent, for example, up to a fifth of the new cases among this population if we can just get that first prescription in people's hands. What we also saw was that by and large, if people did not pick up that first prescription, that 1 in 5 people who are not picking up that first prescription, 70% of those people did not re-engage in PrEP care in that year. So they were essentially lost to care. We also saw that there were some gradients in who did not pick up PrEP. So again, these reversals. So we saw that women, people identifying as female, were more likely to reverse. Young people, people age under 25, were most likely to reverse. Our respondents who were Black new patients who were Black were most likely to reverse, or who had incomes lower than $30,000 a year were more likely to reverse, who had education of high school or less, and Importantly, one of the strongest areas that you see gradient is by cost. So if we look at the out-of-pocket costs for PrEP from $0 to over $500, over half of the people who were experiencing costs of over $500 were reversing their PrEP. So this really also points back to this is a matter of equity. We already start seeing inequities in even who gets that initial prescription for PrEP. And some of those gradients are happening by age, by race, by income, and then by cost, who's being charged. On the matter of cost, we also looked across cost, and we saw that there was a gradient in who reversed or abandoned, and abandoned is those people who didn't come back. And if we look at people who were charged $0, 8% of people reversed prescriptions, 6% abandoned. So again, the vast majority were not coming back, and that was at $0. However, when you look at up to over $500, over half of the patients were reversing PrEP, and nearly half were abandoning PrEP. So we wanted to play this out a little bit because we understood that the PrEP and the nature of PrEP costs could change, especially in this landscape with the Braidwood case, as well as some other things that are happening that I'll talk about at the end that might change costs for PrEP. And so we did this simulation that essentially looked at what happens when someone has a current out-of-pocket cost and what happens if that out-of-pocket cost changes to higher or lower. So the blue represents what happens if costs increase. The green is what happens if costs were to decrease. So in the first step, if we looked at people who are currently paying $0, even people who were now asked to pay $10 for PrEP, the rate at which they would abandon their PrEP, that is not pick up the PrEP any time in the year, nearly doubled, just at a low cost of $10. Obviously, that gets even more extreme when you think about people who are moving from $0 to $500. But if we look the other way around, if we looked at people who are currently paying over $500, 48% of those were not picking up PrEP at any point during that year. That reduced just to 7% if they were now charged $0. So we think that here's some of the things that we could expect as costs change and as these different legal cases and other political tools play out. In short, what we found, and in summary, that an increase from $0 to between $100 to $500 in monthly PrEP out of cost would increase PrEP abandonment rates by 6 times. And we found that resulted in more than 1 in 3 patients never filling their PrEP prescription. And again, even a small increase from 0 to 10 would double the percentage of patients never filling their PrEP prescription. We also saw that within each of these cost tiers, that when you compared those who abandoned PrEP compared to those who filled PrEP, new HIV cases were, up to 2 to 3 times higher. So the rate of new HIV cases over the following year was 2 to 3 times higher among those who abandoned their PrEP prescription, reinforcing why cost is important, not just to people getting PrEP, but to actually preventing new HIV cases. So what can we do here? Well, there are a couple of things. Right now, the Biden administration does have a proposal to cover PrEP at no cost for people on Medicare. That's currently awaiting a final decision from the Center for Medicare and Medicaid Services, CMS. So hopefully that decision should come out any day, and we should have more information about whether or not that this will be covered for Medicare. There's also the PrEP Access and Coverage Act that was reintroduced in Congress in June 2023. If that passes, that would require all private and public insurers to cover PrEP at no cost. And beyond that, we had a session a couple of weeks ago. We really think that there's still a need for a national PrEP program. As Dr. Patel, as you saw in that big schematic that Dr. Patel pulled out, there's a lot to navigate, even when costs are low. So we need to ease this navigation in addition to keeping PrEP at $0. Thanks so much for your time today, and thank you to the funders who supported this work. Back to Dr. Millet.
And thank you, Dr. Dean. Really a tour de force presentation on how cost still matters, even at what we might consider, nominal costs, $10, and showing that as many as 10 or 11% of people will not come back to pick up their prescription is incredible. Also important for you to show, the demographic groups that were not picking up prescriptions, which are exactly the groups that we need to be on PrEP, from women to younger people to other groups, So thank you again for a really terrific presentation. At this time, I would like to open it up for questions for each one of our fantastic presenters. As a reminder, you can raise your hand, or you can go ahead and ask a question within the question tab of Zoom. There are already a couple of questions that I believe that we have waiting for us. And the first question was asked by Wakefield, and let me see if it is still there. I no longer see it in here. Wakefield, do you want to come online and ask their question?
Sure, happy to come online and probably feel more like making a statement. First of all, thanks to all of you for your presentations, and say that I was particularly challenged by the fact that all of our solutions tend to look at a medical model. Sorry for the sunlight, we don't have it often here in Seattle. But you know, I heard Dr. Patel say that we can't look at PrEP care without looking at the office visit, the lab, and the delivery costs. And a lot of the conversation today has been around cost. I'm a Black man who's been on PrEP more than 10 years. I do not need a medical professional to manage my prescription by sitting me in an office 4 times a year as a person who suffers from challenges with white coat syndrome, asking me about my sexual activity in order for me to continue to get my prescription. There are self-test kits for HIV. There are more and more opportunities to get low lab cost or have self-test kits for STIs. I'm just wondering, do we really believe that all of the models that are going to work are ones that are going to tie us into historic Western medicine? Or is anybody working on opportunities for people to have PrEP without linking 4 times a year to Western medicine providers?
For the organizers, I can take that. I think thank you for your wonderful comment, and it's true. This is kind of a concept that we've seen actually all over the world where people are exploring. So I think there's a great push to try to use the self-testing kits and to have more kind of seamless integration into getting a prescription, whether that's like a teleprep or through you know, other types of models for care. And I think you know, also cash shifting the ownership of who can provide that prescription is very important. We saw in Washington State and other places where you can just walk into your local pharmacy and probably get a prescription. So I think there's efforts around there. And I think in general, this is the advocacy about changing the laws in each state. And, you know, we have a very localized legal system. So Washington State's doing something, and that something's very different than Missouri, let's say. So I think it's that call to action to change some of the healthcare laws.
I live in Washington State, and believe me, it is still onerous.
Thank you both. And I just want to put in a quick plug that there is going to be another presentation that AVAC is having that's going to address this issue of self-testing and PrEP implementation. So I'm sure that we can put some additional information in the chat where we can discuss this a little further. There was a couple of other questions that came in during the presentation. There's a question from Ben Ryan. Ben, do you want to come offline and ask your question?
Hi, I'm just good. Can you hear me?
Yes.
Okay, I'm sorry, no video, not prepared. But you did allude to the Braidwood ruling, and so I've been reporting about that, getting ready for NBC to write about it whenever the ruling comes out. The general feeling from lawyers is that, well, for one thing, they tossed out the religious liberty bit, so it's more just the notion of will ultimately the appeals court and then the Supreme Court void the authority of the U.S. Preventative Services Task Force to mandate coverage and, importantly, to mandate with no cost sharing. So in the event that that does indeed happen, I'd love to hear some of you discuss what you feel the repercussions will be, coverage, cost sharing, tiering, and that sort of thing, and ultimately uptake, adherence, HIV incidence.
I can start here, especially since we just emailed about this.
You did. It'd be great for the rest of the group to hear about it, I assume, right?
So I think part of the challenge in answering this question is that we are in a very dynamic space right now. So if we just took, for example, the Braidwood case in isolation, I think we're pretty much, I think, assuming that costs would increase or costs would go back up. So people who currently are protected under no cost sharing, that would increase. And we've already seen in the simulation study that I showed you that could dramatically increase. Even small increase in PrEP costs could really upend whether or not people are picking up their first PrEP prescriptions. However, we also recognize that states might have their own remedies. That if the Biden administration acts, right, they can kind of come in and at least get some people under Medicare covered, and that other things might happen. So I think what we're hoping is even if Braidwood goes in a direction that could lead to cost sharing, and again, that Braidwood decision could have implications for the USPSTF's authority on a lot of things, not just PrEP.
Indeed.
Right, it could have really wide-reaching implications. We think and hope that there will be some other political tools that will kind of be in place that can help protect people from costs dramatically increasing. But again, if costs increase, I think we all predict that we're going to see a drop in people's ability to access PrEP and PrEP-related services, because we know that's been such a driver and such a barrier for so long. Others want to weigh in on this?
I mean, Greg, I'd love to hear your thoughts as well, if you have any.
Ben, I don't have any thoughts on this. This is, unfortunately, most of my work has been more in the global field recently,
Sure.
and I haven't been following this as closely as I would like.
I mean, the only other thing I'll say about this, and it's indirect, is, but sometimes I think as we get kind of snicky about our levels of evidence and directionality and causality, but I mean, just the fact that jurisdictions that have PrEP programs have higher engagement and higher PrEP equity, I mean, I think that kind of is the answer. Like if we want to know what's likely to happen if changes happen that increase out-of-pocket costs, it's likely that that's going to have a negative impact on equity. I think it's sort of putting together several pieces of information and making some assumptions. But if we want to predict what's going to happen, I think that's what I would predict would happen by everything that Dr. Dean has presented and by what we've observed about the impact of affirmative, positive changes in reducing barriers to healthcare are associated with more uptake and more equity. And so things that negatively bear on financial access to these important treatments is likely to have the opposite effect.
A safe and unfortunate projection based on everything we've seen over the last 12 years. So
yeah.
Great, thank you, Ben. We have several other questions that are coming in. The next question is from Harold Phillips. And Harold, are you willing to come offline and ask?
Sure. Hi, everyone. My question was, and I'm going to try to find it because I wrote it out here as well, was for Dr. Patel. As you talked about medical acquisition and the buy and bill models, I wanted to get a sense from you because CMS is about to issue their guidance regarding Medicare and putting PrEP in either Medicare Part B or Part D. And can you speak a little bit about the impact that will have on the buy and bill models? And is there one that's better that the community should be advocating for?
Thank you for that important question, Harold. So I don't know if there's a link between what type of Medicaid and each part linked to buy and bill versus the pharmacy benefit. So I do need to have that disclaimer, I don't know that exact link. And so as we're advocating, all forms of insurance coverage should be pharmacy benefit, if possible. We've seen that with, you know, in general generics and the oral PrEP. And that's just to say, from the standpoint of getting the medication, buy and bill requires people to have the capital on hand. And imagine if you're a federally qualified health center and you need to have, you know, 200 injections. Now, I want to give you the framework. You know, Legacy Health in Texas has 2,000 injections that they're administering just in the last couple of months for their 300 injectable PrEP users. And remember, each injection is well over $4,000. So what's happening is the buy and bill process requires you to have money on hand to buy and then to bill later. And we don't have the staffing power at each organization to also do all that minute paperwork. So you got to remember also, in this framework, you send a piece of paper to an insurance company. They say, oh no, you forgot this. It gets sent back. And we just wonder how many times somebody at any institution, whether you're an academic facility, an FQHC, has the ability to go back and forth. So to answer your question, we just need to look at the fine print and see if it's pharmacy benefit. And I'm not saying that's the overall best answer. I'm saying in general, we have seen in the field, pharmacy benefit is a little more easier than buy and bill, and it has left people out of delivering cabotegravir because organizations cannot afford more than X amount of thousands of dollars to buy the injection on hand. And they've seriously said on their website or at the provider visit, we can't do it, here's the referral place, and I hope you can get in.
Thank you.
Are there any others who wanted to answer that question as well? Okay, our next question is from Gerard Radivosian. Gerard, are you online? Are you able to ask your question?
Yes, thank you, Greg. Hi, everybody. Thanks so much for all the great presentations. It's been really helpful. I typed my question in the chat, but I wanted to ask about a very wonky issue around ACA risk adjustment. And and by the way, I'm a consultant to Yale and the HBTN 096 trial. When I was reviewing the comments on the 2025 NBPP rule that was just finalized a couple of weeks ago, there were some comments from insurers around arguing that without adequate risk adjustment transfers, some insurers make it harder for people to access PrEP and stay on PrEP, despite all the ACA protections that Dr. Patel and others covered. So I'm curious how much of this is an issue that folks have heard about. I don't know if this will be covered in the CMS rule that's forthcoming, or if this is another fight to have for the 2026 rule. But I guess general question around PrEP, accounting for PrEP and ACA risk adjustment and how that impacts insurance behavior. Thank you.
Is there anyone who would like to answer? Okay.
I'll just say I've not heard of this issue, so I'm actually going to look it up just as you're bringing it up. I appreciate you bringing it up. I haven't heard this yet.
Yeah,
I also want to ditto what Lorraine has said, and I want to add a concept. What we all should be worried, and especially in the clinical situation when you have very short windows, like 2 months is short for us when we're trying to reach out to someone, call them, bring them back. They take off work, they take a sick day, they lose money. Every time there's a situation with acquiring the medication, that happens every injection or every prescription. So all the things that the audience is asking and we're discussing today, I want to remind everyone it's every cycle, and that cycle can now be every month, because when you load for an injection, it's every month. And so there's insurance changes, and then on top of insurance changes, you've actually switched a plan, but then within plan, they're switching. So 1 month you got it, and the next month they change the fine print and you got to do a new referral letter. We've had that a lot with the injectables during early rollout. And so I just wanted to highlight like all the changes, intra-plan, inter-plan, and that is what is exhausting the system, both at the provider care level and the client level. And then the client is just like, this is not working for me.
Thank you, Rupa. And that's actually a very nice lead into the next question from Kenyon Farrow around multi-month dispensing. Kenyon, do you want to ask your question?
Yes. Hi, everybody. Great presentations. My question is for Dr. Dean, I think. So one, great presentation. So we talked before about these issues and how they get overlooked. But I had a question about whether or not is there any research that has looked at the difference between getting one 30-day, supply versus getting, say, a 90-day supply of, PrEP meds in terms of even return, to pharmacy for another pickup? Because I'll just tell you, I, have used the generic, but since I recently switched new insurance, I'm getting a generic, but it's the Teva generic, which is still pricing at, $17.99 per month. That's, $1,799 a month. And so all of a sudden I'm switched back to getting a 30-day supply when I was getting a 90-day supply, when I was getting cheaper generic on another insurance plan through a different manufacturer. So, and it's a headache, frankly, to have to go back, even for me, once, to go once a month versus how widely convenient it is to just pick up a 90-day supply and not worry about it again. Plus, it gets timed around, with the 90-day supply was also timed around my normal doctor visits. So I just, just even for me in this work, I could kind of like plan around those things together. So I'm curious to know if there's anybody who's looking at that difference in, PrEP, this, kind of pickup.
So I don't know about the other speakers, but when I saw your question, I scrambled to try to look back at the papers that I had read about the other discrete choice experiments that I had tried to read. And actually, I didn't see any of them that compared 30 to 90-day prescriptions. But what I would say consistently is that people are always preferring more convenience, right? So to your point, I think that's one of the reasons why we saw people saying that they had preferred injectables, because we're saying, I think the injectable was coupled with only having to kind of be seeing someone once every 3 months. So I can't say that we've looked at it, even though it's something we probably could look at with our claims data. But in general, it seems like people are, whenever there's a more convenient option, it's associated with greater adherence and retention. Doctors Patel or Sullivan, have you seen any specific studies comparing 30 to 90-day?
I have not.
Lorraine, oh, sorry.
Go ahead, Rupa.
Lorraine, I need to look at the data from Kenya, because when you look at the methods section, I think they're dispensing 90 days. So in the United States, the insurance coverage issues mandate some of the fills, but as advocates in the room, we should be advocating when appropriate that providers do 90-day fills. And in fact, that's what I practice. So I hope more people are in tune with like writing that very verbatim on the script. And I think it's very easy to get auto-corrected by a pharmacy as a provider or by the insurance. And so it's the call to action for the advocates to talk to the providers that like be aware for auto-correction, because it's cheaper for the pharmacist. I think there's some economic incentives to get you to 30 days versus like 90 days. But with that being said, I think there's literature in like diabetes and other fields that talk about multi-fill, month fill, and health outcomes and adherence. And I was just trying to PubMed that on the way here, but I couldn't, like, during this. And then if I remember the method section on some of the pharmacy-based data that's coming out of Kenya and other locations, I believe they had more than 30 days in the method sections of the allotment of pills.
Thank you for that. The only thing I would add, I was going to say the same thing, which is I think in other fields, like in cardiology, for example, where they're essentially maintenance medications, there's evidence that the sort of adherence or compliance rates with medication, but staying on is higher when 90-day prescriptions are written.
Okay. Thank you. Appreciate it.
Thank you all. We're coming down close to the end of this portion, but before we do, Rupa, you had mentioned the Whitman-Walker model, but you really did not give a lot of information on it. Would you be able to just walk us through really briefly on what that model is? I believe that you're on mute.
Sorry, thank you. So this is a case model of where in the clinic, and that's important to note because it is what a DC health law allows in terms of injections. So in the clinic, there is an entire floor, an entire system dedicated to the peer specialist, PrEP specialist clinic, and it involves hiring through the union approved job descriptions, the delivery of PrEP by a person that has no traditional medical license and is obviously trained within the system, but can deliver phlebotomy, so laboratory draws, injections, and can have a follow-up visit. And the methodology in which this is nestled in is that a provider will write a prescription and do an assessment, and that is a provider that has a medical license, such as a nurse practitioner, a physician assistant, or a doctor. And then you can have follow-up care for the rest of the year with the peer specialist, which has fostered a greater connection, reduced medical mistrust, allowed for convenient and flexible timing in the evenings. And this one-stop shop has also allowed these community health workers to generally have more time than your traditional medical visit, and they've been able to go and pick up the medication for the client too from the on-site pharmacy and have that ready. And then whenever a situation is identified for acute care, like acute respiratory infection or a change in mental health status, immediately the peer specialist is able to link the PrEP user back to their primary care system, or if there's a vaccine that's needed, etc. So it is a clinic that is run by peer specialists with the vision of how they want to deliver care to help their community.
Great. Thank you, Dr. Patel. I think that that's something that's extremely useful and something that others would certainly would love to take a look at. Now that we're coming to the end of this portion of our program, I was hoping that each one of you could just give us a quick nugget of what you think should be a take-home message or a take-home activity that everyone online should do around the whole issue of PrEP equity. We'll go ahead and start with you, Dr. Dean.
Sure, and I'll give an upfront caveat, is that my comment is kind of really thinking about the US context, but especially in a place as resource rich as the United States, no one should have to decide between their pockets and their PrEP. That's the way I feel about it. Sorry, that's not the opinion of the NIH, any of my funders, or Johns Hopkins University, but that's how I feel. And I think that we should be doing everything we can. I mean, there's just no reason why we shouldn't be able to continue to offer $0 PrEP. Other than the political will to do it. Let's keep fighting for it. Yeah.
Thank you. Dr. Sullivan?
I'll start by saying what Dr. Dean said. This is where she is in my Zoom. The thing that I would emphasize is that that we know that prioritizing programs and trying to address these barriers to get PrEP to communities at the highest risk is also good public health and will result in the greatest public health good. So one thing I wish that the programs would do is start using PrEP equity metrics to monitor their progress as one way of monitoring their progress. And I think if that was on the monthly or the quarterly discussion about how are we doing, it's just not how many people are we are getting onto PrEP or receiving PrEP in our jurisdiction, but it's how equitable it is. And I suspect that, as in many endeavors in public health, that sometimes getting PrEP to communities that have more barriers to accessing it will cost more, but it's the right thing to do, and it's also the best thing to do for public health. So I would encourage the regular use of PrEP metrics as one way of evaluating, how we're doing and guiding choices.
Terrific. Thank you, Patrick. Dr. Patel?
I, of course, want to echo what Lorraine and Patrick have said, and to complement the cost advocacy in reducing out-of-pocket payments. I would like to have the call to action where we're taking that legislation to our mayors and our governors, and when we have technology that is more like directly observed administration, where you can actually go to someone's home and help them out because they want you to be there and meet them where they're at and deliver the new PrEP technology, whatever it is, today or tomorrow. We haven't been able to optimize some of the technology, not only because of the cost, that is definitely the issue, but I, as a provider, haven't been able to bring it out of my clinic and have other people help me, in the workforce, because the laws that I live under are very strict. And that is very different than if you stepped outside of the United States and you went to some parts of the world where you could actually delivery of many things in a village by community health workers. So in addition to the cost fight as a take home, I'd love to have the complementary advocacy for differentiated service delivery by different people in different places. And that is going to take door-to-door knocks with example legislation in hand and asking our mayors to change it. And it's actually easier than we think. So I hope there's no perceived barriers in that.
Great. Thank you, Dr. Patel, and thank you to all of you for really thought-provoking presentations, very timely presentations in terms of where we are with PrEP and how we might move forward. And now I would like to turn it over to our co-sponsors of this seminar, Andrea Weddle from HIVMA, as well as Jeremiah Johnson for PrEP for All.
Jeremiah, do you want me to go first? Okay, I'll lead up. Okay. Well, thank you so much, Drs. Dean, Patel, and Sullivan, and Greg. Really fantastic. And I guess my quick summary would be coverage matters, systems matters, and cost matters. But which can be really mind-blowing, because right now they're drivers of health inequity. But what I really appreciated that you all three did was you laid out policies and models for how we can turn that around, and they can be drivers for health PrEP equity, ultimately health equity for everyone too. And so I think you really gave us a roadmap, and I appreciate that, and inspired me in particular to continue work and to work continue our strong advocacy for our national PrEP program. And so with that, I will turn it over to Jeremiah, and just thanks again, really terrific.
Yeah, just echoing the same. So much gratitude to amfAR, which has remained a steadfast supporter for PrEP for All for a long time. Lori, Rupa, Patrick, you really are the cool kids of PrEP right now. Just really, really glad that you're here. Jim, thank you so much for all of the work to get this together. Webinars requires so much behind the scenes work, and you don't even realize, and to be able to get close to 400 people you signed up for a webinar for this important conversation is a real feat. And I just want to say, and of course, enormous gratitude to Andrea and HIVMA for always being just an amazing partner in everything we do. And I want to shout out PrEP in Black America as well, which they just had an amazing pre-summit on research in Seattle, and just a lot of really great work being done on PrEP and equitable PrEP access, and it's really exciting. Just quickly want to make sure that we plug some of the advocacy that's happening. So you've heard it referenced to, you've heard a lot of the conversation, and it's really driving home a lot of these different points. And I'll share a few slides in just a moment to talk about that. But just want to say that everything that's been touched on in this conversation is so much the inspiration behind the advocacy that we're trying to do. And the notion is that we need to meet people where they're at. We're not just trying to sort of like quilt together kind of a patchwork system that almost maybe covers people, but not really. We want PrEP as a public health intervention. We want to show that it's going to end HIV as an epidemic. And per Patrick's presentation, we may not be able to in the United States get to ending HIV as an epidemic without PrEP. And I think that's an important point to take home, because for over a decade of PrEP advocacy, I've had public health officials say to me, PrEP's great, but it's really going to be test and treat that ultimately gets us to the end of the epidemic. I think that, we've been arguing against that for a long time. And I think we're really starting to see some of those results of that in the system. So it really is necessary. The fact of the matter is it's too complicated for people to access. We haven't learned those lessons from COVID, to Rupa's point, that if you're going to get a preventive intervention out there, it has to be where people are already at. It can't have cost as a barrier, and it can't be super complex. And that is so much of what is inspiring the work behind a national PrEP program and what we're really focused on. And I think also just want to call out, some of the comments from people like Wakefield and Kenyon and myself, that personal experience also is important to drive forward solutions. I'll say for myself, part of why I'm so obsessed about this is that I was diagnosed with HIV myself back in 2008. I happened to be part of the Peace Corps. And a really fortunate side effect of that was that the Department of Labor covers my PrEP-related expenses for the rest of my life. So I've never had to worry about losing a job and losing coverage. A big reason why I'm such a pain in the ass for so many people is because I've had the freedom to live my life and be an advocate, because I haven't had to worry about the complexity of American healthcare and will I be able to live or die. And I believe that for PrEP users, that same freedom should be afforded to them. And I think that that's so much of what drives us forward and why we want people to join us and be part of this conversation. And so just quickly, I am going to share my screen and give you some concrete ways that you can all get involved as you are able. Are you able to see that? Great.
Gorgeous.
You're gorgeous. Okay. So just briefly, because when we say National PrEP Program, what does that mean? Because there are a lot of things that we're talking about in terms of equitable scale up. Just want to drive home that so many of the things that we've talked about here are the inspiration. And this single slide does not effectively communicate all the complexity, that we have to navigate in the American healthcare system. But just to say that, we're calling for pathways towards simple cost coverage. We're calling it a PrEP pass. It's a complicated ideal to get toward, but what we think is that the end result needs to be this simple for people, that they can download a pass, have something that's intuitive, they go to the pharmacy gets reimbursed for distributing a medication there, that they go and get their labs done, that the labs are reimbursed through that same mechanism, that it's really simple and intuitive and not fragmented in the way that it often is for un- and underinsured populations at this moment. Right now, we're having this conversation around generic PrEP because it's super duper affordable and it's a great option for the vast majority of PrEP users. But we also believe that if we can solve this and create systems and infrastructure that help make equitable PrEP access possible. It helps us to have those coordinated conversations for injectables, for other preventive health interventions. Very curious what we could do for doxypep, for example, if we had infrastructure. This is something that Dimitri Daskalakis said a lot in terms of the mpox response. It was much easier for him to get to HIV positive individuals because of the Ryan Wright infrastructure. For highly at-risk HIV negative individuals, it was much more difficult because we don't have a national PrEP program or something like it. So we want to get to that. So we have cost coverage. Rupa, to your point, we absolutely can't only rely on sort of, the clinicians that exist who are giving great care but aren't always accessible and oftentimes are overworked. And so we're talking about what is that network expansion. Some of that's bringing pharmacists in there. Some of that is through telehealth. Can we turn a homeless shelter? Can we turn an LGBTQ center into places where people then have access to a PrEP prescription via telehealth? I think this feeds in a little bit to Wakefield's comment. That let's meet people where they're at and not turn it into a bunch of clinician visits. I think to Wakefield's point, we also need to make the guidelines a little simpler. And I think that that's something to talk about as well. I think there's also an interesting model being put forward by Julia Marcus and Doug Krakauer about over-the-counter PrEP. But I think those are some interesting innovations. But this is how we're talking about this in terms of a national PrEP program outside of that regulatory piece. And then finally, we can't build these great programs and not get it out to the communities that need access the most, and really let them know about it in a way that is accessible to them. And so we need to have a buy-in for community sort of demand creation pathway. And we need all of this to happen simultaneously. It can't be just one thing at a time. People are experiencing multiple barriers. And as Laurie's presentation said, when we lose people, sometimes we lose them for good. We need to make sure that we address them simultaneously and don't just try to do one piece of this. It's got to be comprehensive. So that's my quick pitch. If you believe in this work, we're pushing this forward in a number of different ways. President Biden has put forward for the past 3 years a mandatory proposal for $9.8 billion invested. Congress is complicated, so we're also pursuing, as a coalition, discretionary appropriations funds to build a pathway toward that. And so right now I'm inviting you, if you are part of an organization, this is US based, just to emphasize that, because I know we have some great global partners here. But you can scan this QR code or go to this link and sign your organization on for a letter that we are sending to appropriators in Congress, hopefully in the next week, to advocate for bridge funding toward a national PrEP program. And I'm sorry to move so quickly. Hopefully you've scanned it. If not, you can reach out to us. Hopefully someone can put this in the chat as well so that people have access. If you yourself are a PrEP user or a former PrEP user, or someone who wants to be on PrEP but haven't been able to get onto it, Michael Chansley at PrEP for All is doing some great work around mobilization around this. We have started the PrEP Saves PrEP Users Union, P2U is what we're calling it. We want to get your stories. We want to get you connected with policymakers. We want to bring us together to have level setting discussions where we can teach each other. And if you want to get involved with that, if you want to be part of a PrEP Users Union, please join us. You can email Michael at prepforall.org or go to prepforall.org/prepsaves and sign up and be part of that. And then finally, if you haven't seen it already, we released back in March an amazing report in partnership with the Southern AIDS Coalition. Shout out to Will and Defina and everyone down there on equitable PrEP access and some of the policy and regulatory barriers that we see in the US South. And so really invite you to go to our website, go to SAC's website, download that, and look up more information there. So with that, I'm going to stop sharing. I know we've gone over, but many thanks for sticking with us.
Thank you so much, Jeremiah. And again, I want to, give some love in the chat through your emojis, what have you, but let's give some love to Greg, Patrick, Rupa, and Lori for superlative moderation and amazing, really actionable presentations that we can all take home and work on together. So thank you for that. It's not a matter of if, it's a matter of when, and we have it in us to make this happen. So again, much appreciated for all of them and for all of you for joining us today on a Friday. Some of us are in the late afternoon. Just really appreciate all of you coming together. As a quick reminder, we will be sending out a follow-up email likely on Monday with these resources. So that email will point you to where the slides are, the recording, and we have collected all of the URLs and links in the chat, and we'll be popping those into a resource document so you can go back and refer to those in case you weren't able to click on every single link that was shared or you may have missed something. So all of that will be coming soon. And now we are 5 minutes after, so basically we're right on time. I hope you all have a great Friday, rest of your Friday into this weekend. And then we're gonna get working on this ever more strongly next week. And before we know it, we will have a national PrEP program. We have to call this into being. We have to be positive and optimistic, even amidst all of the drama, all the complexity. We have to fight this fight and know that it is worth winning. So again, thank you. Thank you to our speakers, our wonderful sponsors, Jeremiah and Andrea at PrEP for All and HIVMA, and of all their colleagues, and all of you for all the work you're already doing, all the work many of you are already doing to advance PrEP equity in your jurisdictions. We recognize that this is going to take many responses and all of us working together. So thank you for that. With that, I'm going to close the call and wish you all adios, adieu, see you later, and hope to see you on May 16th for the webinar on vaccine discovery. Ciao.